Welcome to the latest podcast from Staffordshire and Stoke-on-Trent Clinical Commissioning Groups. I'm Penny Gibbs, and today I'm joined by Dr. Murray Campbell to talk about cancer and his role as a GP. Thank you so much for joining us today on this podcast. Can you tell us a little bit about yourself firstly? So how long have you been a GP for in Staffordshire and Stoke-on-Trent?
I came to Stafford in 1988 and joined the general practice vocational training scheme then. I'd actually qualified as a doctor in 1983, but I did psychiatry training for 4 years and then decided that I wanted to spend a little bit more time or return to general medicine for a bit whilst I planned my future, and I've remained in general practice since then. Initially the training, and then I've worked mainly in the Cannock Chase area.
And you've got a particular interest in cancer, haven't you? So can you just talk us through when that became part of your role or interest?
In addition to interest in cancer, I think it sort of flows more from an interest in promoting patients' awareness in their own conditions and perhaps promoting patients' self-care in their own conditions. I think that was what sparked the interest, because there's a lot of self-care which might surprise people when it comes to cancer care. And I think the two interests tied up quite nicely. And so therefore I actually just saw a flyer, like many other people, for a role as a Macmillan Cancer Care GP facilitator. And that was about 3 years ago now. And since then, I've certainly learned an awful lot about cancer care, and more importantly, the resources that are there out with general practice to support these patients.
So what did that involve in your role then? Because obviously you're a GP anyway, so how were you kind of balancing both being that Macmillan champion and what did that see you doing that was different?
I'd got to a stage whereby that I was looking to reduce my commitment within the practice, but still had enthusiasm for other clinical roles. I felt that this is a sort of role that I could, really get involved with.
I think what was really interesting, in last week's episode, we talked about the 72nd birthday of the NHS, and it was really clear in one of the milestones that we were reflecting on that actual, screening and treatment for cancers has been around for decades. Can you just describe some of those screening and treatments that's available at the moment?
There is screening for 3 of the most common cancers: bowel screening, breast screening, and cervical screening. Now, I think my main interest in those is to try and promote the increase in uptake in the screening programs. It's, many countries don't have screening programs, yet we do. And I don't believe they're nearly as well utilised as they should be. And there are many reasons, obviously, behind that, over and above the current situation that we find ourselves in. So even before coronavirus, we saw that all the screening numbers were in fact dropping. But in cancer, we have national priorities. And these priorities are to increase the number of people surviving cancer, but also diagnosing far more cancers at an early stage, at stages 1 and 2, whereby there is far less morbidity involved. There are 2 issues with that. The earlier we detect cancer, the better survival, obviously. But not only that, perhaps more relevant to the fact that more and more people are surviving cancer and living with cancer, certainly from a Macmillan point of view, where cancer care is about improved patients' experience of cancer, the consequences of treatment are responsible for the quality of life that people have after their diagnosis of cancer. And the later diagnosis of cancer, the poorer survival, but also the more interventions and treatments that people have to endure, and resulting from that, often the quality of life. So we look at statistics and see our survival rates are improving, and we, perhaps we do regard that as a good thing, but I don't think we can ignore that people living with and beyond cancer are not always living well.
So, whilst the coronavirus crisis has been taking place and has been with us for some time now, has that affected services? I mean, has that still been there? I know GPs have still been open, but do you see that affecting things going forward now?
I think we have. I mean, obviously there has been a dramatic change in the way practices are functioning and working. But general practice is very, very much open, although getting a face-to-face consultation is not the norm at present. So therefore, if anyone has symptoms that they fear may be serious, then that is an important message to take away. The other thing is that the GPs, and if you go on to, there's various resources from the NHS and cancer, the big cancer organisations, Macmillan, Cancer Research UK, all of them have got a section about coronavirus on their websites. They've all got excellent resources anyway, but they've all got specific coronavirus areas. And that can be very helpful for patients who are perhaps worried about differentiating symptoms. And there are a lot of resources for professionals who are having difficulty differentiating those symptoms.
So it's clear that cancer services are a priority for our area. And like you said there, GP services are still open. Acutes and hospital providers are still open, and for those I think that have perhaps got treatment booked in or appointments, continue with them if you've been told.
Absolutely, and again, plugging the resources, both Macmillan in particular and Cancer Research UK have got a series of sections on their websites addressing all these specific areas. How do I manage if I've got cancer during COVID-19? And it's got all this, it raises all these issues about treatments, changes in treatments.
So bearing in mind that we think statistics have dropped for people getting their symptoms checked, why do you think there is that gap?
In research, even before COVID, showed considerable challenges that we had in raising patients' awareness of common cancer symptoms. Now, I think it's certainly an issue, particularly in the UK, that our patients have got actually, obviously very generalised, but have got a very poor awareness of common cancer symptoms. So patients don't present early anyway in the best of times, and that causes delayed or potential for delayed diagnosis.
So the current statistics say that 1 in 2 of us are likely to develop cancer in our lifetime. So that must be quite a lot of patients that you see that do develop some kind of symptoms along the way. How do you prepare yourself as a GP to talk to somebody who potentially actually has cancer, and what kind of conversation do you have?
Early on in a consultation, we may well have suspicions of cancer. And sometimes we can't win. We raise those suspicions, and then it turns out not to be cancer, and we get letters from relatives saying that we've given their relative months of hell or worry or whatever. But I think the important thing about assessing symptoms is that if we've got suspicions about cancer, after the importance of the screening programs, which picks cancer up at an asymptomatic stage before symptoms develop, and that is easily the best way of detecting cancer at an early stage. When we refer for cancer, it does not mean that we have got a high suspicion of cancer. It means that we have got a suspicion, but that could be a low suspicion, and by far the most likely outcome is that the patient will be excluded from having cancer. Now, previously, I struggled with those conversations because I didn't want to worry the patient. And so therefore, I would refer a patient on what's called a 2-week rule or a 2-week pathway, which is a cancer pathway. But I wouldn't tell them that because I didn't want to have this conversation that you're talking about. Now, what came to me, and this was interesting, but this came to me in the role that I've now got as the Macmillan Cancer Facilitator, the feedback I got from secondary care. And one of the astonishing things I got about the feedback was the number of people who did not attend their 2-week referral. We know do not attend figures are a problem for NHS across the board, but I was quite staggered about the statistics regarding people not attending for their 2-week referrals. And this is because we have to get this balance right about telling people that this is a cancer pathway, but reassuring them that it's really to exclude cancer, not confirm cancer. And this is, I often get feedback from my colleagues, we don't want to frighten our patients, but I would argue this is one of the skills perhaps we should have when it comes to consulting, is being able to explain that situation. As a bit of a plug to my colleagues, perhaps, we talk a lot about reviewing our cancers and seeing if we could have done things differently. Now, we've always done that as doctors. One of the first things we do is if we get notification of a patient's death or a devastating diagnosis like cancer, we will invariably look through the notes and see, could we have done something different? And we are formalising that process more now, but we've always done that.
So thinking of the other side to this as an example, then I'm sure you see regular patients, perhaps those that have got long-term conditions, and you're seeing them on an ongoing basis. For the ones that have had cancer of any form and have received treatment and it's been successful, and maybe you've had a part of that, perhaps persuaded them to take up the screening, or you've been part of that referral pathway, or as your Macmillan champion role, you've been supporting them. That's got to feel quite good.
Yes, I think we can sort of congratulate ourselves on occasion, and I can think of examples. Interestingly, I can think of examples whereby I think I've done a really good job, and I've picked that up at an early stage. And I can think of one occasion in particular, whereas I made a slightly unusual diagnosis, but I think we've always got to reflect a little bit upon, again, back to the patient experience, and it's got to always come back to that, because the example I'm thinking of, I felt I'd done a good job. In actual fact, we had a multidisciplinary meeting with our colleagues shortly after, and I raised this, and one of my colleagues, a community nurse, said, "Oh, I bet you got some brownie points for that diagnosis from the family." In actual fact, the family responded in a completely different way. They felt that I not had delayed the diagnosis because I'd made the diagnosis at the first presentation, but because I'd gone down the routes that we tend to follow, that detracted from the diagnosis, and the patient didn't do well because of the diagnosis and the outcome of that diagnosis, not from my involvement in it. So I think the whole thing about cancer is it often comes back to patient experience. There's a very interesting statistic that when we diagnose cancer, 1 in 6 of our patients lose confidence in the person who makes that diagnosis, the GP who makes that diagnosis. And that goes up to 1 in 3 where there is a there is an actual delay or a perceived delay in that diagnosis. And I think the reason I raise that is because the diagnosis of cancer is one thing, but back to where I come with my Millen hat, it's about patients' experience of cancer care. And we should never forget that, because the diagnosis is one part of the step or one part of the journey, and it's a very small part of that. And it's so important that we maintain the confidence that our patients have in us. And we should reach out to the patients after a diagnosis to see, well, where are we now? How can we support you? And I think that's the bit of cancer that certainly Macmillan are extremely involved with. It's back to this living with your cancer, and more importantly, living well with cancer. I mean, some of the times you can feel quite embarrassed. I've got patients who come in and say, "You've saved my life." But in actual fact, I've just done clear-cut symptoms and I've referred them in a 2-week. I think that's always a difficult one. The other side of the coin is that I'm much more likely to remember the patients that I have missed. And I would be very surprised if any of my colleagues sitting in the position cannot reflect on 1 or 2 patients we have missed with cancer. And I suppose a couple of the important messages are, some cancers are difficult to diagnose, so always consider reviewing people. And that's something that's been lost a little bit in general practice. We are perceived much more of a one-stop shop in general practice now. There's less opportunity to review patients. In addition to that, we should not be reassured by negative investigations. And I think one that does come back always to haunt me is I got a patient who had been referred by a colleague on a 2-week pathway, and the consultant's letter came back stating, "Please do not utilize my 2-week referral process for patients with hypochondriasis or whatever." So I subsequently saw this patient and I was worried about their symptoms. But in view of that letter, I didn't re-refer them in a 2-week late. I referred them routinely and then upgraded that to urgently. And by the time the patient was seen again, they were riddled with metastatic cancer. And I think we've always got to be aware. I think we're probably more aware of our failures, if you like, than our successes.
So the important thing throughout the whole of this is people being seen early if they suspect they or someone that they love has symptoms. Can you just give us a quick overview of what they might be? Now, I totally understand there's going to be different symptoms for different cancers, but are there any kind of just general things that people need to bear in mind and to get checked out?
There's a few big ones, and perhaps particularly relevant at the moment. Cough is cough in a smoker is always a worrying symptom, but a lot of people smoke and a lot of people cough, and that creates a problem. And of course, one of the key symptoms of COVID-19 is a persistent cough, but not all coughs are cancer and not all coughs are COVID-19, but I do think a persistent cough, particularly if someone's coughing up blood. Blood is always a worrying symptom. Again, I would argue blood in a cough, blood in vomit, blood in poo, blood in wee. They're symptoms that should never be ignored. And weight loss and new lumps and bumps. I suppose those would be, there's probably many, many more. But in that point, again, patient awareness. As a GP, we often get people coming in and saying, "I've been a bit naughty, I've been in the internet." I've got nothing against the internet, as long as it is a recognised website. So the NHS websites have got information on cancer and common cancer symptoms. Macmillan Cancer Care, whole areas about cancer symptoms, and Cancer Research UK as well. And each individual cancer charity has often got a symptom awareness section. So I think, again, one of the key messages would be pointing people to well-recognised websites is something that I would want to encourage.
And you can find a number of those resources and links to the cancer charities in the description of the podcast. Don't forget to join us next time on our podcast series.